tuviera que enumerar todos los grados académicos que tiene este personaje, me demoraría muchos minutos y la jefa me mataría. Así que vamos a dejar ahora a un viejo conocido nuestro. Y ya es imposible sacar la cuenta de cuántas veces ha venido a ayudarnos en un sinnúmero de formas para el desarrollo de la especialidad. Sea como sea, aquí se encuentra el doctor William Billy Mallon, urgenciólogo del LA County Hospital, profesor titular del programa de Medicina y Urgencias del Keck School of Medicine, director del Fellowship de Medicina y Urgencias Internacional de la misma universidad, past president del Colegio Americano de Urgenciólogos del Capítulo de California, miembro fundador de varias academias, entre ellas la Sociedad Chilena de Medicina y Urgencias, y recientemente galardonado con un premio de la ACEP que se ha dado solamente a 30 personas en toda la historia, y que es el Outstanding Contribution in Education. Nombres como Tintinali, Rosen, Hoffman, Walls, Matú acompañan a la placa del doctor Mallon en el ACEP. Así que démosle un aplauso de bienvenida.
Thank you. All right. So the timing is good. We had Isabel with hard penises. We had Rob Rogers with penises coming out of the ass. And so the stage is now right for me. I don't have to worry much about being politically correct. So that's good. You know, when you come to the Catholic University, you have to worry about when the time is to get politically incorrect. The time is now. They asked me to talk about sore throat. Sore throat. What could be there to say, really, about sore throat? Right, it comes in, they either get antibiotics or they don't. Maybe they get some sympathy and some Motrin, and they go home. Sore throat. But Stuart Swadron this morning reminded you that there are cases that you might see 1 in 10,000 sore throats, maybe even once in a career. And in emergency medicine, your diagnostic vocabulary, the breadth of the differential you entertain is really important. So we're going to start with the idea of sore throat and strep throat and extend to a broader diagnostic vocabulary. Yeah, me. Yeah, the place. It has graffiti now. That was when it was new. Now, graffiti. The school colors for the dean, and we're a sponsor. I have no real conflicts. Nobody's really paying me. I'm not rich. But Sonosite, they're out there. They did help me make a movie, which we showed last year, called Code Black, which is doing pretty well. So what is our menu for the day? So our menu is the sore throat that is not strep throat. So kind of first we have to say what is the sore throat that is strep throat, and then we'll go to what's not. But we have sort of a list here of things that are kind of interesting, a couple of diseases that begin with L, a few that got the Q, and some other viral stuff that we're going to talk about, including some weird things like diphtheria. The last case in Chile was, I think, 1997, according to the WHO. And so let's talk about these odd entities that come in as a sore throat. So there you are, checking the throat. Beautiful doctor. Thin, healthy patient. It's not the way it is at my hospital. First you have me, not a beautiful doctor. And then the patient's usually not so beautiful either. This is the type of thing you see in a textbook which immediately induces sleep. You could have had 5 double espressos. You open a textbook to that page, you're like, oh God, help me. Children, seasons, rashes, too many things. It doesn't help you. So let's just remember the basics about how we do strep. How do you make a diagnosis of strep? It's clinical. Usually no cultures. Sometimes the pediatricians, I don't know what's wrong with them, but they send cultures. You don't need cultures. A positive culture doesn't tell you that the patient has strep, and a negative culture doesn't tell you the patient does not have strep. Cultures are useless, expensive, and they give me the result 2 days later to call the patient back. Bad plan. Bad plan. But anyway, we go with either the center score or the McIsaac score. Very simple. If they're near the top of the score, they have a 4 or a 3 over here, or they have a 5 over there, or a 4. We say clinically, oh, it's strep. And so we just treat it as strep. Is that true? Do those people who have a 5, do they have strep? It's not as true as you think. With the highest scores on either McIsaac or the center score, you get about 50% of them, you'll be right. You say, you have strep, your center score is 4. You have strep throat. No, about half the time you'll be right. The other half of the time you'll still be wrong. Most of them are viral, nothing important. Not important of viruses. But every once in a while, there's some other evil shit that is masquerading as strep throat. And so if you're an emergency physician, you have to harness your inherent paranoia. One of the jobs of emergency physicians is to be paranoid. You have to always be thinking about evil shit. People at conversation at the table want to know what's wrong with you because you're always thinking about evil shit. But that's it. So we're going to talk a little bit about that. And even there's other strep. It's not all group A strep. There's new group C and group G causing problems. Strep is a very smart bacteria. As soon as you squish down some strep, other strep pops up. It's very hard to get all the strep pushed down. And this is the typical chart they show you. It's very straightforward. If it is high, then you treat them empirically. In the middle, if you feel compelled, you could do a rapid strep test. It would be best if the rapid strep test was a third-generation strep test because the sensitivities and specificities are quite a bit higher. And then they say low, consider other diagnoses. But the false part of this is not over here. Of course, considering other diagnoses is great. But the false part is this part, that you think you've established that it's strep. And we will talk about some diseases which would be center 4, but they're not strep. So you still have to think. So I remember I was working in jail in the emergency room. We have a jail in our hospital. It's very nice. I looked in this guy's throat, and I saw something almost just like this. I was like, what is that? And so I remember sort of smelling his breath. That was a mistake. Don't do that. I learned nothing by smelling his breath, other than it was unpleasant. But then I did stick something in there and try and push on that thing because I didn't know what it was. And it broke. The white thing broke. And it started bleeding. And I was a third-year resident. So I said, that's weird. So I called infectious disease specialists and I said to them, I remember in medical school they told me about this gray cornflake on the throat. And I think I have diphtheria in the jail. And the consultant said to me, no, it's not. I said, because I'm very rational. Yeah, I think it is. He said, no, it's not. I said, how can you tell on the phone? Long pause. No, it's not. Yes, it is. No, yes. Anyway, it was diphtheria. So why do I show this? Because emergency medicine has an important job in public health for surveillance. Diphtheria is gone. It's largely forgotten. But diphtheria is very patient. In Chile, like in the United States, like in parts of Canada, like in Russia, it's just waiting for you to forget about it to come back. And so in the United States, we thought it was gone, and it came back. I saw one of the cases, one of the first cases in Los Angeles, and the public health measures got brought in. 2 months ago, I was working in the emergency room, and I saw someone with a high fever and a weird rash, and it was the first case of chikungunya virus in Los Angeles. And public health had to go out and spray for mosquitoes and tip over the pots and get rid of the water. There is a connection between surveillance for rare disease and notification of public health. Emergency medicine, we sometimes forget, has a public health role. So I show this case to remind you, diphtheria is waiting. Someday, one of you will look in, I've never seen another case, I've only seen one. But someday, one of you will look in the throat and you'll have to remember basic stuff that's long forgotten. And believe yourself when you see it, it's diphtheria. These are the other things that you would find out. There's no new information here. It's in every textbook, but they get, by the way, they meet center criteria. They'll have lymph nodes. They won't have a cough early on. Later they get a cough when it crawls down their trachea. They start coughing. But initially, that sore throat is a 4 on the center criteria. If you fall asleep at the wheel and call it strep because it was a 4 on the center criteria, then you miss the opportunity. Viral badness. Lots of sore throats for adenovirus, coronavirus. It's a cold. You got a sore throat, you got a cough, you got a little bronchitis. It's a cold. But there's some badness in the viral world, and sometimes you got to think about it. So the first thing is mono. The reason mono is so important is because it's not just a disease of the throat. They may end up with splenomegaly, hepatitis, pancreatitis. You should be able to tell the patient, you might be sick for a month. And you can't tell that. That looks like strep throat to me. No, that's mono. I could have pulled up the references, but there are about 6 papers that say, can you tell when you look in the throat what the disease is? And they used to say, oh, if it's pus, it's bacteria. No pus, it's viral. No, that's mono. That looks like pus to me. You can't tell by looking in the throat if it's a virus or a bacteria. If you think you can, you're lying to yourself. This person is center positive. They have a center score of 4. They might have a McIsaac score of 5. But it is not strep throat. So you cannot fall asleep at the wheel just because you're going to do it. Again, basic stuff. But it would be a mistake not to recognize this and tell the child, the teenager, oh, go ahead and play soccer. No problem until you rupture your spleen. So there's some education, some information, some downstream consequences. It started as a sore throat, but this is a different entity that you need to know about. And the usual picture of a smear. Here's another sore throat. I know we don't think about it that much, but it comes in with a sore throat and a headache. Maybe the history, patients don't always tell you, but you have to ask the questions right. Oh, have you been traveling anywhere recently? I could have added in the country list, I could have added Peru and Brazil. I'm going to Brazil next week. It's not on a sex vacation, I'm going for emergency medicine. But the person who comes home from that trip with headache, lymphadenopathy, sore throat, particularly a lot of retroorbital pain, you might think you need to do a lumbar puncture on them because you're thinking viral meningitis. As soon as you have that thought, you have to start connecting the throat with the sex. We'll do a little more connecting of the throat to the sex. I told you we would get to an inappropriate place soon, but we'll do it in a moment. And you have to remember that if you send a regular HIV test on this person, swing and a miss, strike one. You need to send an HIV RNA because it's acute infection. You're here. You're right there. So you need to send an RNA if you want to pick this patient up. And if you do that, maybe his wife will be spared the problems down the road. And maybe other contacts as well. Again, a very important sore throat to identify. And it might look like this. This is an HIV positive lymphoglandular acute infection. Notice the gums are kind of red too. This happens with this. Now, I love looking at the pharyngitis literature because no one wants to really talk about gonorrhea in the throat. Gonorrhea is kind of disgusting. Only the French acknowledge that gonorrhea is an important cause of sore throat. When you read everyone else's literature, they list all the causes of sore throat. They don't list gonorrhea. The French, it's a quarter of all sore throats. Just another reason to consider going to Paris. But here you can see gonorrhea sore throat in Philadelphia, in the East Coast of the United States. But you want to, again, you're going from a sore throat to the sex. What have you been putting besides empanadas in your mouth? And so oral sex history, you'll see it more often with gay men. And in women, the sore throat will often occur before vaginal discharge and pelvic inflammatory symptoms, which often take weeks to develop. The sore throat, which has copious pus, a pus waterfall, the person will be swallowing pus, and it's because of what they were putting in their mouth that gave them GC. And so this sometimes you have to remember. If you see a throat that looks really kind of nastier than it should, you might start asking what's been in that throat. And so we have the transition. Do you get the joke here? We went from cocksucky sore throat to cocksacky. You get it? Yeah. It's not often that you get to pull that one off. Cocksucky, cocksacky. So another sore throat that we happen, and this summer in Los Angeles, we actually had a very bad year for Coxsackie virus. I had a 26-year-old woman die on me with complete heart failure from myopericarditis. We could not keep her alive. We were thinking of going to ECMO to bypass. Stuart talked about RECMO, resuscitative extracorporeal membrane oxygenation. We were considering it. 26 years old, she died of myopericarditis. And sometimes I saw a patient that my colleague passed on to me, 30 years old, they were going to send her home, and they were calling it fever of unknown origin. I'm like, you can't send fever of unknown origin home in a 30-year-old. They're like, well, we didn't find anything. I'm like, well, as I often say to residents at the bedside, it's not about more questions, it's about better questions. Go in and talk to her. So they tried, and anyway, it took me 2 seconds to get to the fact that both of her kids, their feet had peeled all their skin. Both kids had lost all the skin off their feet. It was a clear case of Coxsackie. They had said, oh, we gave her 2 liters of fluid, she was dehydrated. I was like, what do you mean she's dehydrated? Well, her pulse is still 120, but we're sending her home. I'm like, whoa, 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 whoa. Now I got Coxsackie virus with an abnormal heart rate that didn't respond to 2 liters of fluid. Time to do an ultrasound. She had a pericardial effusion and pericarditis. They were assuming her heart rate was dehydration. It was not. So herp angina is a very specific sore throat. Involves only the palate. In the adults, you don't often see the hand or the foot thing. It's missing. But if you see that sore throat, that's not strep. That's a very distinctive sore throat with red borders, a little serpiginous shape to it, clearing sort of ulcers in the middle. It's a diagnosis at a glance. If you look in that throat, you should just say, herp angina, Coxsackie virus. Then you have to get into the question, is it group A? Is it group B? Is it the type to be invasive? Is there cardiac involvement? Should I consider sending other tests? They have belly pain. Should I consider sending a troponin? Do they get meningitis from it? Sometimes you'll see this other version of acute hemorrhagic conjunctivitis where you see these bloody eyes and you're not sure what to think about it, but they've had a febrile illness. It's also Coxsackie. And it's the midsummer sore throat, right? Most of the other illnesses are not midsummer. They're fall, winter, spring, wet, cold, raining. The midsummer sore throat deserves some respect as the possible Coxsackie virus. Here's another one. This is considered in the United States to be an emerging pathogen. I do not know if there are any cases so far in Chile, but I have already seen multiple cases in Los Angeles. Younger patient, a sore throat that used to be here and now is here. And you're like, what do you mean? No, it's over here. And you look at the skin, there's nothing to see. Maybe it's a little red. You press on it and they go, ow. So it hurts, but it's not like there's a cellulitis on their neck, only very at the end. The skin overlying is quiet. No signs of infection, but the neck is tender. And you find yourself asking questions you know are stupid. Did you sleep wrong last night? Maybe it just hurts because you slept on the wrong pillow. You know that's not it, but you're trying to find a stupid reason to accept an important symptom that you don't know what to do with. Sort of like, wait a minute, yeah, you slept wrong. It's your fault, like it was said earlier. When we don't like what we're doing, we point the finger at the patient. You slept wrong. No, it's this Fusobacterium necrophorum. You don't need to know much about medicine to know that that name is not good. It has the word necrophorum in it. I don't know if it's Greek. I don't know if it's Latin. I don't know what it's got dead shit in it though. And eventually they get pulmonary emboli. And there's the gram-negative deal. Yeah. There's the thing in the neck. This is late. They start having swelling. It's a clotted internal jugular. And eventually that clot, which has this Fusobacterium necrophorum in it, will embolize to the lung. And so you'll get lung symptoms and a cough, and maybe even hemoptysis. Maybe you would have got a chest x-ray. Those are little balls of Fusobacterium necrophorum in the lung late in the disease. And this disease is now popping up. Much has been written about it. In fact, Center, the guy who made the Center criteria for strep throat, has said that this disease is more important than strep throat. Recognition of this is really important. And you can't tell when you look in there whether they have the Center criteria, because they don't have a cough till the end. So these patients are Center criteria positive, but they don't have strep. These are three that I saw, one in the jail, one with hemifacial edema, and none of these facial edemas, Rob Rogers was just talking about SVC syndrome. This might look like a hemi-SVC syndrome with facial edema and suffusion that doesn't look right. And they tend to fail their antibiotics. And you're like, yeah, the antibiotics never work for strep throat anyway, right? We've been lying to patients about that for years, right? When a patient has strep throat and you give them antibiotics, they get better in 7 days. If a patient has strep throat and you don't give them antibiotics, they get better in a week. The good news is that if you do give them antibiotics, you'll be able to see them again for diarrhea or vaginal itching. In the United States, we believe diarrhea is the cure for sinusitis, ear infection, and sore throat. That's why we give really expensive antibiotics to punish those people who come to the emergency room and demand them. Here's your $200 antibiotic and a roll of toilet paper. Please drink plenty of fluids and think of me fondly. But here you need to break out the flagell for this, gram-negative. And here's another case of full neck. So you just saw an x-ray just like this. That was the facial edema with Pemberton sign where the face got red. But this person's arms, you put their arms up, their face doesn't get red. And what happens is you sit them up to look in your throat, and this is a kid, right? You can see, what do we got there, a 5-year-old, 6-year-old? You sit this kid up to look in their throat, and the kid starts screaming and pushing you away and lays back down. And you're like, what? I want to look in your throat. You sit the kid up, the kid gets into distress and lays back down. And you finally get a look in the throat and you're like, I'm not that impressed. I didn't see much. There was no pus. You might have had a vague sense that the back of the throat was a little forward. It was coming at you. But you never looked in this kid's throat before. You don't know what the kid usually looks at. Maybe he's got a fat throat. I don't know. It seemed a little... I see a lot of fatness. He's got a fat throat. I love my fatness. Anyway, so you don't know what to think. You certainly don't have these images yet. But there's something about retropharyngeal abscess that I told you that's really, really important. Almost every airway problem in emergency medicine, you all know this already. They want to sit up. They want to get sniffing. They want to open everything up. They prefer to be forward. But this kid, I told you, wants to lay down. Every time you sit this kid up, they're unhappy because when you sit them up, the space in their throat gets bigger and more full and increases their airway obstruction. When they lay back, it flattens out and they can breathe better. This is the only airway that wants to lay down. When you encounter that, the airway that wants to lay down, ask yourself what's happening in those prevertebral soft tissue spaces. And then it's time to start thinking about a CAT scan and some other things for diagnosis. And many times these kids will tell you, oh, I'm an asthmatic, I was intubated 4 months ago. Sometimes not, but sometimes they've had an airway manipulation. I don't want to talk about some of the easy ones, but you have to put Ludwig's in. I think Ludwig's is an easy diagnosis, right? It's a person with bad teeth, that you open the mouth and the tongue is 2 centimeters higher than it should be, a crepitant full neck. But you can't have this conversation without at least mentioning Ludwig's. So to mention it, to be complete, we've done our deed. How about the 2 Qs? There are 3 Qs here, but I like the Qs. No one calls them the Qs anymore. We see quinkies, uvular edema. The first time you look in there and you'll be like, sir, how long have you had a Chardonnay grape hanging in the back of your throat? Grape. It comes 2 ways, the big fat grape or the long one that goes down, that this looks like a string hanging down their throat. And this is Quinkie's uvular edema. It's the first time you see it, you'll be like, I don't know what that is. It doesn't look normal. And you can just poke it with a TB syringe with a little epi and it will like weep and be gone. And sometimes you can give it an inhaled treatment and it will with inhaled epi and it will be gone. It works great. And sometimes people want to call it anaphylaxis or some allergic, and it's not. It's Quinkie's uvular edema, and it comes and goes. And sometimes you'll see a patient like this who's been smoking a rock cocaine pipe, and how did it happen in them? And then they sucked the superheated screen out of their pipe, and it went to the back of their throat and it made this noise. So they cooked their uvula like it was a beautiful steak, and it looks similar. With the burns, there's often a little bit of necrotic area. And then a quinsy, also very obvious diagnosis, peritonsillar abscess. But remember, there is something to be gained by looking in the throat, because you'll see stuff. And then there's this one. So we talked about the painful side of the neck. I want you to think of Lemierre's. What about it's painful in here? And oftentimes, even in a white person, you won't be able to see redness. And certainly in a black or Hispanic person who's got darker skin, you won't see anything. But it hurts, and they have more dysphagia than they should. And they might have had a sickness 2 weeks ago, a viral illness. And they're tachycardic, and someone says, yeah, they're not taking POs well. We gave them some fluids. Well, what's their heart rate now? It's still 130. Give them another liter. 130. Shit, stubborn bastard. Give them another liter. 130. Impressive. He seems to like 130. Get a TSH. Oh. Now you know that his heart rate is not due to dehydration. he has de Quervain's, painful subacute thyroiditis, and eventually he's going to be hypothyroid. So it's a triphasic disease. More dysphagia. The pain is here. It's not in the throat. You look in the throat, you don't see jack. It hurts here, over the gland. And by the way, don't mush on the gland too much because you'll make the thyrotoxicosis worse. This is not the time for thyroid massage. And you can treat them with beta blockers and NSAIDs and maybe steroids. And if you have some concern about whether they have Graves' disease, you can do radioiodide uptake, which in this disease will be 0, to clarify it. But usually if you listen carefully to the story told by the patient, because most of the other causes of subacute thyroiditis are painless. This is the only one that comes to the emergency room because my throat hurts and I can't swallow. Painful subacute thyroiditis is de Quervain's. By the way, if you send a sed rate, you'll think they have temporal arteritis. It's not uncommon if you send a sed rate on these patients, they got a sed rate of 100. You're like, whoa, who was thinking that was there? Because they don't look like they got a sed rate of 100. They look pretty good. They look pretty good. And they will do you pretty well. But it's one of these entities in there that you don't want to miss because you fell asleep at the wheel of the sore throat workup. And my clock hit 0. That was exactly time. Thank you very much. Stupor.